Hi, my name is Roya Etemad-Rezai, and I am a thoracic and body cross-sectional radiologist at London Health Sciences Centre, University Hospital, and Schulich School of Medicine. Today's lecture is going to be about thoracic radiology and an approach to chest X-ray. So let's start with the basics. Let's talk about X-ray densities. The X-ray densities are very similar to the alphabet of a new language. If you're learning a new language, you need to know the alphabet in order to put sentences together that make sense to you. Same thing with X-ray densities. So if you look at the X-ray density spectrum, you can see that you have anything that's very lucent or dark or black on one side of the spectrum, and the other side of the spectrum is anything that's very dense or white. And I've written up here all the different tissues that correspond to these densities. So anything that's very dark or black is going to contain air, and you can see that in the lungs, for example, or in a loop of bowel. The next density that's a little more gray is fat density, and fat is pretty easy, so you can see that intra-abdominal fat or subcutaneous fat. The next one, now we're getting closer to the white portion of the spectrum, is soft tissue, and soft tissue is probably the trickiest one because it includes different things. So for example, the muscle is a soft tissue density. Any kind of fluid is soft tissue. So blood or urine or pus or bile is going to be soft tissue. Any of the solid organs, so your liver and spleen and kidneys, are going to be soft tissue density. The next one is calcium or calcification, and you can see calcification in any kind of tissue. So the pericardium can be calcified, your vessels can be calcified, for example. The next one is bone, and any kind of bony structure, so the vertebral bodies, any of the long bones, the skull, any of the bony structures are going to be pretty dense. And then the densest or the whitest structure that you can see is actually metal. It's a density that people are not born with, but metal is actually inserted into the body, and you can see that in surgical materials such as suture material or an arthroplasty or a nail, and also any kind of foreign body that people, for example, may have swallowed or ingested. That's going to be very white. So here are a couple of examples. This is an X-ray of a lower leg. The bone is actually pretty obvious. So the long bone, the tibia and fibula, are going to be pretty dense. The next density is soft tissue, which is the muscle. And you can see how it's not as white as the bone. So that's the gastrocnemius muscle. The next one is fat. So this is subcutaneous fat. And again, it's less dense than the muscle. And then gas or air outside is pretty black. There's another example. This is a lateral view of the knee, just to show you the difference between the density of the metal, which is pretty white, against the density of bone. And then down here we have calcification. There's the popliteal artery, which is calcified. So you can still see it, not as dense as bone, but it's denser than soft tissue. Okay, let's talk about some surface anatomy. If you look at the person from the front, the two lungs obviously are going to be occupying the majority of the chest cavity. The right lung is a little bigger than the left. It's about 55% of the lung volume. The left lung is about 45%. And then we have two fissures. On the right side, you have the minor fissure and the major fissure. The left side is easier because there is only one fissure. If you look at the person from the back, most of the lung that you see is going to be the left lower lobe. Only the top of the left upper lobe is going to be seen on a chest X-ray if you're looking at the person from the back. And again, most of the image belongs to the right lower lobe on the back, and the right upper lobe is just the tip of the lung. Let's look at a lateral chest X-ray. If you're looking at the right lung, again, there are two fissures. You have the major fissure that runs at an oblique angle, and you have the minor fissure that runs more horizontally. So if you use the two fissures as imaginary lines on a lateral chest X-ray, you can figure out what kind of a lobe you're in. So if you know where your minor fissure is, anything above the minor fissure is your right upper lobe. Anything below your major fissure is your right lower lobe. And everything in between the two fissures, anteriorly on a chest x-ray, is the right middle lobe. So always remember this triangular shape, which tells you where the right middle lobe is. If you look at the left lung, things are easier. There's only one fissure, and again, it runs at an oblique angle. Everything above the fissure is the left upper lobe, and everything below is the left lower lobe. Okay, how do we look at a chest x-ray? So not everybody looks at the chest x-ray the same way. Most people develop an approach or a style of how they look at a chest x-ray or any other x-ray for that matter. For example, some people like to look at the lungs first, then they go to the heart, then they look at the soft tissues. Some people like to look at the structures from the top to bottom or from the outside in. It really doesn't matter how you look at a chest x-ray, as long as you have an approach, you have a style, and you stick to that style, and not forget to look at certain hiding places. So when you look at a chest x-ray, most people look at the lungs first, and then the cardiomediastinal silhouette that's in the middle. So we're going to go over a normal chest x-ray and all the usual contours and all the usual silhouettes and what makes up all the contours and what to look for. So when you look at a chest x-ray and you look at the heart in the center of the chest, the heart in most people is usually left-sided. So most of the heart should be to the left of midline, and the midline is the spine. So you should see more heart to the left of midline than to the right. And then the heart has contours. So it has a left contour and a right contour. And the left contour of the heart on the bottom down here is made up of left ventricle. The right side, however, is made up of the right atrium. And then there's a small area on the top that is made up of the left atrium. So if you're wondering if the chamber is enlarged, for example, if it's a left atrial enlargement, you're going to see a little bulge up here. If the left ventricular enlargement, the left contour of the heart is going to be bulging out. The aortic knob or knuckle is this rounded contour that's just above the atrium. It's not always seen in everybody. Especially young people may have a smaller aortic knob. As people age, the aortic arch gets more calcified and it becomes larger, and sometimes it becomes very unfolded. So you might be able to see the aortic knuckle or knob, as it is called, in older people better than in younger people. Then we have the airway or the trachea. Again, remember that this is a normal chest x-ray. You might not see the trachea as straight as this in everybody. In this patient, the column of air comes down. So there is your trachea, aerated, and then at the point where it bifurcates into the left and right mainstem bronchus, we call that area the carina. So remember that this is the carina. For example, if you're looking at somebody who's intubated, you want to see the distance of the ET tube from the carina. This is where you want to look for. The diaphragms, there's a left and a right diaphragm. Usually, the right diaphragm is higher, but not always. The reason being that you have the liver, which is the biggest solid organ, sitting inferior to the right diaphragm. You should be able to draw a line from the lateral aspect of the diaphragm all the way to the medial aspect in a normal person and be able to see this area, which is the costophrenic angle, quite sharply. It's called costophrenic. Costo comes from the rib and phrenic is a diaphragm. So the angle between the rib cage and the diaphragm is called costophrenic angle. You have a left-sided one and a right-sided one. And this is an angle that becomes really important when you have, for example, fluid in the pleural space or you have a pneumonia in the left lower lobe. This costophrenic angle becomes obliterated and you don't see it as well anymore. We also have cardiophrenic angle. So cardio from the heart and phrenic is the diaphragm. So this is the angle that is made up of the side of the heart. On the right-hand side, you have your right cardiophrenic angle. Left-hand side, the same thing. And again, this area can be filled with pericardial fat pads, so you might not be able to see the cardiac apex very well. Or for example, you can have some fluid or adenopathy or a hernia that's going to obliterate this cardiophrenic angle. Another angle to be aware of and always look for, this angle should be sharp in normal chest x-rays. The lung apices are basically the top of both lungs, and this is an area that can be missed quite frequently when people look at chest x-ray. The reason for that is that the top of the lungs are very busy areas. You have the clavicles coming over, and you have multiple ribs that are projecting over the apex. So it's very easy to actually miss a soft tissue mass or a vascular abnormality or a rib fracture. So an area to pay extra attention to when you're looking at a chest x-ray. So the clavicles are the two long bones that are running at sort of a horizontal angle on either side. Very important to pay attention to the proximal and the distal ends of the clavicle, and also look for example, fractures or dislocation of the head or the dislocation at the AC joint. So then we have the rib cage, and there are 12 pairs of ribs on each side. And remember that the anterior ribs come at a different angle compared to the posterior ribs. The posterior ribs are more horizontal. The anterior ribs come at a different angle, sort of an oblique angle. And the posterior ribs are probably easier to see, but you have to pay attention to them, especially if you're looking for a fracture, for example. So if you look at the left side, so this is the first anterior rib. There is the second one, number 3, 4, 5, 6, and so on. Whereas on the other side, the posterior ribs, so there is number 2, 3, 4, 5, 6, 7, and so on. So the spine is along the midline, if the patient doesn't have a scoliosis, obviously. And the spinous processes are these small, round, dense structures. So every vertebral body has its own spinous process, and you can see them sort of lining up like that along the midline in the thoracic spine. If you want to assess and see if the patient is rotated or not, you want to take one of the spinous processes that you can see well, and also look at the proximal heads of the clavicles on the left and on the right, and then look at this distance. So in a patient who's very well positioned along the midline, who's not rotated, this position between the proximal head of the right clavicle is the same distance to the spinous process as the left head of the clavicle. If distance is widened, that tells you that that patient is rotated to that side. Then we have the mediastinum and the hyla on either side of the cardiac silhouette. So you have the left hilum and the right hilum, and the right hilum is usually a little lower, but not always. And the hilum is sort of an ill-defined area of increased density, and it is made up of vessels and airways coming out. So your main stem bronchi are coming out there, and your pulmonary arteries and your pulmonary veins are coming out on either side. So if you look at this chest x-ray, so the pulmonary vessels are tubular structures, and depending on how big or small the pulmonary artery is, the hilum is going to be larger or smaller. But this is sort of the angle at which the pulmonary vessels are coming out. And then they're branching out, and they get smaller. The branches get smaller as you go closer to the periphery. And then if you look below the left diaphragm, you usually see gas, and that's usually bowel gas, and usually the stomach. You can also see the left colon, or sometimes small bowel gas can be seen inferior to the left hemidiaphragm. And in a female patient, you're going to see breast shadows on either side. And remember that the breast is usually made up of fat, and the increased fat density is going to cause increased density in the lower aspect of the chest. So if you look from the top to the bottom of this lung, the top of this lung looks darker or more loosened compared to the bottom. And that's not for any pathology. It's just because the increased breast density increases the density, the overall density of the chest. And that's why the lower lungs look a little denser. Now let's look at a lateral chest x-ray. So there's the front, the back, the patient standing with their arms elevated above the head. And the first structure that's really important is the trachea. So again, remember, this is a normal chest x-ray. You can see the column of air quite nicely. It comes straight down. And again, this is the area of bifurcation into the left and right mainstem bronchi, which is called the carina. If you look at the heart on the lateral view, so if you look at the front of the heart, the area that makes up the anterior aspect of the heart is your right ventricle. The left ventricle is posteriorly located, so the back wall of the heart is made up of left ventricle, and the top of the back of the heart is your left atrium. Then we have this retrosternal space, which is basically a space filled with air above the heart, and this space can be filled if your right ventricle enlarges, or if you have, for example, a mediastinal mass, or if you can have a hematoma. So anything can fill the space. So always look for this retrosternal air space. It should be filled with air, and if it's not, you have to start thinking what is occupying that area. Then if you look at the back of the heart, so remember, this was your left ventricle, this straight line, which comes down and it goes towards the diaphragm. This tiny little line is the IVC, and you don't always see it, but if you have a normal chest x-ray and the person is taking a nice big breath, you might be able to actually see the IVC. Then on the lateral view, we see two diaphragms, and the question always is which diaphragm is which. And some people think, well, it's easy. The one that's higher is going to be the right hemidiaphragm. And that might be so in some cases, but not always. You need a rule that's going to apply to every case. So remember, the heart in most cases is left-sided. So the heart is sitting over the left hemidiaphragm. So the diaphragm that starts from the back and comes all the way to the front is the right diaphragm. The diaphragm that starts from the back and is stopped by the heart. So remember, this was the heart. The diaphragm that stops at the heart, because the heart is sitting on top of it, is going to be the left diaphragm. So that's an easier way to remember that. And then remember, we talked about costophrenic angles on the frontal view. Well, the same angles continue on a lateral view. And again, you have a left-sided one and a right-sided one, and this angle is basically a potential space for fluid to collect or for any other pathology, such as pneumonia, for example. So if you cannot see your posterior costophrenic angle sharply and nicely, something is occupying that angle. Vertebral bodies are pretty self-explanatory, so we usually don't see the cervical spine because it's usually hidden by the soft tissues of the neck and the arms, but we do see the thoracic vertebral bodies quite nicely, and you want to look at the height of the vertebral body and make sure that it has a square shaped, and also the disc space in between should be equal. In front, we have the sternum, and again, depending on the patient's size and how much subcutaneous tissue they have, you might be able to see the sternum very well or not. And the lateral view is a good view if you're looking at the continuity of the sternum. For example, if the patient has trauma and there is sternal fracture, you want to look at the lateral to see if you can actually see the continuity of the sternum. And in case of a fracture, you might actually see some retrosternal hematoma, for example. Then we have the aorta. Again, you don't always see it as well as this. So the aorta, the ascending aorta comes up here. Then you have the aortic arch, and then the descending aorta comes all the way down. And sometimes the aorta can be very unfolded, and sometimes it can be very calcified. And again, remember that the aorta falls either over or anterior to the spine. The mediastinum on the lateral view is a tricky subject because if you remember, the mediastinum was made up of the two hyla, the left and right, And if you look at the lateral view, the hilum is seen on sort of a two-dimensional image. So it's this area on top of the heart, on the bottom of the airway, and it has sort of a rounded opacity. So the hilum on the lateral view is made up of the left pulmonary artery. And if you remember, the left pulmonary artery is a little longer and curves over the airway, whereas the right pulmonary artery is on the bottom and it doesn't have sort of a curved appearance. It has more of a rounded appearance. And if you look at the two together, it looks almost like a shrimp. So the head of the shrimp is the right pulmonary artery, and the body and tail of the shrimp are the left pulmonary artery. And then in between, you have the carina. So this round loosened dot is the carina on the bottom of your airway or the trachea. There is a spine rule, and that's really important when you look at the lateral view. So on the left-hand side, you have a normal spine. On the right-hand side, it's abnormal. So the spine rule says that if the spine was a staircase and you were coming down the staircase, all these vertebral bodies should be the same density. They should not get brighter or denser or wider. So see, all of these vertebral bodies are the same density. If we go to this person, if I walk down this staircase or down this spine, see how the vertebral bodies are getting brighter or denser or wider? So all of these vertebral bodies are much wider than these ones. And if you look at the lateral, this whole area is much denser than this side. And here you had two diaphragms, whereas on this side you only have one diaphragm. So there's something going on in the posterior aspect of this chest that's causing increased density in these vertebral bodies. Okay, now that we have talked about anatomy and all the contours that you have to pay attention to on a chest x-ray, let's talk about radiology language. So let's say you look at a chest x-ray and you want to describe the findings. Okay, let's look at these two chest x-rays. They look very different from each other. You can see that it's easier to read the chest x-ray on the left because the lungs are nice and big and all the contours are very sharp and well defined. The one on the right hand side, not so much. The heart looks very different. The vessels are very crowded and there are ill-defined densities in the hyla. Well, I can tell you that this is the same patient and the x-ray were taken only a few minutes from each other. So why do they look so different? Because on the left-hand side, the patient was told to take a big breath in and hold it. So this is an inspiratory chest x-ray. Whereas on this side, they were told to take a big breath in, breathe out, and hold it. So this is an expiratory chest x-ray. That tells you what a difference a nice deep breath is going to make. So you want all of your chest x-rays to have a nice inspiratory effort. If for whatever reason the patient cannot take a big breath, let's say if they're in pain or they are short of breath, then you're going to have a chest x-ray that's going to be of a lower quality. When you see something like this, you can describe it as well-defined or well-circumscribed. A lesion like this, you may want to describe it as lobulated. It's still well-defined, but now it's lobulated or multiloculated. Well, if you look at a lesion like this, you might be describing it as ill-defined and spiculated. So if you look at a chest x-ray and you call something a spiculated lesion, you're probably describing a malignant mass. Then we have something that can be curvilinear, and that can be an airway, for example, or a vessel could be curvilinear. And then nodular, so nodules are usually round or oval shaped. They're usually well defined, and they have well marginated contours. So let's look at this chest x-ray and see how we can describe the finding. So if you compare the left lung to the right, there is a difference between the density of the left lung. The left lung is darker right? And you don't see the lung markings as well. So the way to describe this side is that there is generalized increased lucency in the right hemithorax, and there is lack of lung markings that I can see on the left. I cannot actually see them on the right. And the reason for that, for example, is that this patient has a pneumothorax. So this is the collapsed lung, and you actually just see the gas or the air in the pleural space. So the right side is more lucent. Compare that to this chest x-ray. So this time the left side is the abnormal side. And if you want to describe it, you can see there is increased density in the left hemithorax compared to the right side, which is lucent. So there's the bottom of your lung. Where's the bottom of the left lung? I don't know, because there is increased density on this side. This is a case that's very similar to the last one. So again, the abnormality is on the left-hand side. And remember, we talked about the diaphragm and the costophrenic angle and the contour of the lung. Well, all of them are present and sharply defined on the right-hand side. But if you look at the left-hand side, the left diaphragm is obliterated, the costophrenic angle is obliterated, and your heart border is obliterated. And if you look at it on the lateral, again, there's only one diaphragm, and we know which one it is because it's the one that starts from the back and goes all the way to the front. So this is your right diaphragm, and your left costophrenic angle is completely obliterated. And again, there's the spine roll. You're walking down the staircase, and all these steps on the bottom are very dense or white. So there is something abnormal sitting down here. And again, if we remember the surface anatomy, this is the left lung. Remember, the left lung only has one fissure, and the abnormalities is below the left fissure. So whatever is going on down here is happening in the left lower lobe. There's another abnormality. How do you describe it? Well, it's very well seen. It's well circumscribed. It's round, very well defined. It's in the periphery of the lung, and it's very dense. So you can call this a nodule, a well circumscribed nodule, somewhere in the right midlung. How about this one? Well, now you have multiple nodular opacities, right? There are different sizes and different shapes. Some of them are rounder, some of them are more oval. And the more you look, the more you see. So there is one, there is one, there is one. Here, there, and there, maybe even one here. And again, remember, you have the hyla. So there's some fullness in both hyla. And the question is this just a normal hilum, or is there one of these nodules projecting over the hilum? So if you want to look at this and describe this, these are multiple well-defined pulmonary nodules, and they're all homogeneous, and they are of different sizes. And they're bilateral pretty much in all lobes of the lung. A very different patient. So you have the patient on the left and on the right. And as you can see, the right-hand side is normal. The left-hand side is abnormal. How we describe this? Well, you might look at this and say, these lungs are really busy. There are so many lines that don't belong there. So this is a linear pattern or an interstitial pattern. And this is throughout both lungs, quite diffuse from the top to bottom. So this is a diffuse increased linear densities or increased in vascular markings in both lungs. And this is an example of pulmonary edema. Okay, and this is the last case. So obviously the abnormality is on the left-hand side. The right lung is very well aerated and of normal volume, whereas the left lung, we can't see any aeration at all. Some people call this a whiteout of the left lung. The way to describe it in radiology is complete opacification. So you have a completely opacified left hemithorax. Then you have to decide where the lung is. If there is still a lung there, so maybe the patient had a pneumonectomy, maybe the lung has been resected, or maybe the lung is completely collapsed, and that's why you don't see the air inside of it. And you know that there is volume loss on the left-hand side because the whole mediastinum and cardiac silhouette has been shifted over. You don't see any heart contour on the right-hand side of the spine. And I don't know if this is projecting well or not, but this patient is intubated, and the ET tube is actually in the right mediastinum bronchus, and that's causing complete collapse of the left lung, and that's why there's complete opacification on the left-hand side. And that concludes the end of this lecture. Thank you.